Hey everyone, welcome back to Yacht Med. I have survived boards and now I'm in my third year doing rotations. And my first rotation was palliative care. It kind of just changed my my perspective on death a little bit. Seeing patients carted down the hallway who had passed away and seeing patients die in real time was really like eye-opening for me. It can be sad, but it's also very beautiful at the same time. It's this natural transition that every single person and every single living thing will have to go through. It kind of helped to alleviate some of the fear I have about death because, oh, this is what happens when someone's dying and everyone's going to die. It also helped me decide that I'm going to fill out my DNR forms like immediately. If it ever happens in the future, I don't want my family or anybody to have any question about what my wishes would be if I was in that situation. So you should fill out your DNR forms too, by the way, PSA. Before I tell you about that rotation, I wanted to go over what palliative care is. The goal of palliative care is to help people with serious diseases feel better, and this is done through preventing and treating the side effects and symptoms of their diseases. And it also incorporates treatment of the social, practical, emotional, and spiritual parts of the patient's care. The idea is that taking care of these things will lead to a better quality of life for the patient. Palliative care can start when the diagnosis is made, and it can go all the way through remission of the disease or end-of-life care. What is the difference between palliative care and hospice care? So they both involve comfort care, but hospice care is initiated when the patient is not expected to last more than 6 months, and the focus switches from treating the disease to basically comfort care, making their quality of life the best that it can be. An example of a typical day would be in the morning I would attend an educational session, and in one of the educational sessions we actually had to practice delivering bad news. What I learned from that is that once you deliver the news, it's best to give them a chance to process what you have said. Some people may run out of the room, some people might break down crying, some people would maybe talk hysterically. So everybody's reaction is different, and what's happening is they have to process that piece of information before you can move forward. That's why the goal of the first visit is to only deliver the news and make sure they understand that. And then moving forward, a follow-up appointment would be made to discuss plan for care and what to do next. Even if the patient appears to be understanding what you're saying, if you talk about these next steps, they are more likely processing what has just been said and they are not absorbing anything that you're saying. And then another thing I learned is to use reflective questions. If you deliver the bad news, just watch the patient and listen to their body language and use reflective questions like, oh, I noticed that you look worried. Can you tell me what you're thinking? Asking very open-ended questions. When I have to talk about a difficult subject with someone, I kind of just want to fill the silence with anything. For me, this increases the risk of me saying something, putting my foot in my mouth, or providing false hope. And then the rest of the day I spend with the doctor and seeing patients, interviewing them, physically examining them. For a portion of the rotation, I got to spend time with the social worker, the chaplain, and some nurses. That was helpful to see different aspects of the healthcare team that take care of the patient. The first week was very emotionally overwhelming. Like if there was a spectrum and like here's surgery where there's not a lot of sharing feelings and it's more like a technical type of medicine, to like palliative care, which is like lots of feelings and emotions are involved. I started out there. It was an interesting ride. I never thought that I would cry in front of my attendings, but I didn't really have a choice. The tears just kind of came. It must have happened like 3 or 4 times. It was just so hard for me to confront death like that, so head on. The culture that I was brought up in, death was kind of a taboo topic and it wasn't really seen that much. And this is the first time that I actually saw death in person, in real life, like happen in front of me. And that was really hard. But I think as time went on, I got more used to it. And something that the social worker said helped a lot. And she said to remind yourself of being a watcher and a walker. So every person has a watcher component and a walker component. And the walker is the one who goes through the motions in life, does their job, it takes those actions. And then the watcher is the part of the person on the inside who's observing what's happening, who's analyzing it, having internal dialogues about it. Whenever I was in these situations where someone was actively dying, or someone was going to die soon, or they're just going through a hard disease process, I would kind of remind myself that, okay, this is not your story, this is their story. So focus on them, and it helped to divert some of my impulses, which were to compare myself to their situation and say, like, what if that was me, or what if that was my daughter? What would I do in that case? What would they do? How would people react and stuff like that? So I think that's when I would get really caught up in my emotions. I was kind of like observing the faculty and the people that deal with this on a daily basis, and I was like, how do they keep it together? Like, this person is dying, like, I don't understand. But I think it's not that they're not feeling emotions, it's just that they've learned to balance those, or like channel them into being able to be there for the patient. In the future, as a provider, if I'm going to be like bawling in the corner of the room and not able to answer the patient's questions or the family's questions and not be there for them, then like that is my role. So in order to do that, I need to be stable and have a handle on myself. And also, if there is something really hard going on, like, all the faculty and staff were so supportive, and I felt like I could be vulnerable in front of them. I didn't really choose to be vulnerable, but it just kind of happened because of the nature of the rotation. But they were all really supportive, and it's important to have colleagues that you can vent to or just talk to about something if it's bothering you, and kind of keep it together in front of the patients. And overall, I really enjoyed this rotation. It wasn't anything like I expected it was going to be. The skills I learned in this rotation can be applied to any field of medicine. There's always going to be bad news. There's always going to be difficult patient and family dynamics to deal with. And it's just, even if I don't end up going into palliative care, I feel like it's important just to know what it is, so that you can refer patients or consult palliative care earlier in the disease process to alleviate the symptoms and the side effects that the patients are going through. Because improving the quality of life and helping patients to live the best life that they can is kind of what it's all about. Some tips that might be helpful if you're going on the palliative care rotation is, I would read a little bit about the history of palliative care and hospice care, and also read up a little bit on the common physical symptoms that this type of medicine helps to treat, like shortness of breath, nausea, insomnia, pain management, lots of pain management, and also learning about the dying process, as well as the process and qualifications to get someone onto hospice care. I hope you enjoyed this video, and until next time, bye!